you for your patience.
No more problem. And the good news is I was already almost done with my introduction, so we're in good shape. You can begin.
Okay. All right, here we go. Can you see the screen now?
Yes, I can.
Okay,
And so
wonderful.
go ahead. Thank you, Dr.
All
Rodriguez.
right, everyone, it is a real pleasure to be presenting to this group. For those of you that don't know me, I did do medical school and residency here. So this is my professional home, my professional family. And so it's a real thrill. Before we get to the objectives, just wanted to discuss why we're going through this in the first place, why we're covering this topic about teaching medical students. And some of this is just as applicable to teaching residents in the clinical setting. So we all enjoy teaching, at least to some extent, and I suspect that was at least one of the reasons why we chose to pursue medicine in academia. Now, ideally, I remember as a resident when I was thinking about going into academia, I was picturing these wonderful interactions with my patients that were never stressed or constrained by time. And then afterwards, speaking with the students about our passion for medicine and all the important topics that occurred during that visit that they might have questions about or that I thought might be worth discussing. And the reality is indeed very, very different. For most physicians, regardless of the specialty, that day is jam-packed, both with patient, or not just with patient interactions, but then there's the documentation, the paperwork, and the inbox management, and the phone calls. And for primary care in particular, there are even more stresses, more challenges, and more demands on our time because we are the coordinators of care. We are the shepherds through medicine. And so all of that is a competing interest. And so in trying to also think about how are we going to teach students, sometimes it becomes something else to do and we lose that passion. And we worry about trying to get it all done in a very short time frame in a way that's effective for the students, but also time efficient and doesn't impinge too much on our patients' interest and their time as well. And so that's what this presentation is about today. It's about talking about some of those challenges and about one method of teaching that has been shown to help to get you on point to do the most important things in your interactions with students, but in a way that is time efficient. So as for our objectives, at the end of the session, the goal is for you to be able to identify the common challenges to teaching medical students in the outpatient setting, explain the 1-minute preceptor, the 5 microskills method of teaching and providing feedback to medical students, and discuss tips for effectively implementing this method of teaching and providing feedback. So let's start with the common challenges. So number one, everybody will probably agree, and this is probably the first thing on everyone's list, is time constraints. Our primary care clinics, regardless of whether it's RBG or the Mark or any of the other locations where we have students or residents, they're all fast-paced clinics. And in addition to that, we have the other demands of providing care to our patients, which includes managing our inboxes, documentation, calls, results management, coordination of care. And then add to that the way that teaching is different in the outpatient setting than in the inpatient setting. The teaching is going to vary session to session, patient by patient, and we do not have in the outpatient setting usually the ability to block out 30 minutes or an hour to sit down with our student and cover one topic thoroughly. Usually they're brief periods of teaching that occurs either within the patient visit itself or immediately after. And there might be some short wrap up at the end of the half day or the day to sum up the main points. So then the next big category is the constantly changing environment. So as we mentioned, the patient type and mix, it's going to change. And although different providers might have different balances in the types of patients they have, RBG and Mark, for example, they all have complex patients, and I think most of our clinics would say that. But those needs and their characteristics change, and so the experiences with the students and the interactions are going to change patient to patient as well. Add to that the constantly evolving technology, and at no time is that more obvious than now, when on the UHS side we see the transition from Sunrise to Epic. And then even for those that already had Epic, for example, on the UT Health side, we're dealing with the transition to telemedicine and learning all the ways we can and should do that. And on top of that, trying to capture all these new ways to make sure we are being compensated for the time we're doing in the non-traditional face-to-face environment. And then add to that COVID-19. And if it isn't COVID-19, in a few years, it might be something else. There's a changing medical environment, and probably COVID-19, more than anything we've seen in recent years, has impacted absolutely every corner of medicine, every specialty to some extent or another. And there's still some other challenges. Another big one is that even our most experienced faculty are still learners. Even as faculty and senior residents, we are constantly learning. There are constantly evolving guidelines. Every day there's new studies on countless topics. And as primary care providers, we have a responsibility of remaining current on the evaluation, diagnosis, and management of the common conditions we see in clinic. On top of that, we have to resolve conflicting data. If only all the studies show the same thing and we had a definitive answer to everything, that would make our lives so much easier, but that's not always the case. And obviously add to that the need to make sure we're adapting whatever data and guidelines are out there to the patient we have in front of us. And then the conflicting guidelines on things like cancer screenings. Those are probably the most obvious ones. And for example, mammograms. Not all of our associations that issue guidelines agree perfectly on how we should care for our patients, or for example, screen for cancer, different kinds of cancer. And then add to that, adopting new payment models in switching from fee for service to some of these new models and these arrangements with the insurance companies and the different payers. We're starting to see list of metrics that change year to year that we're trying to make sure we're meeting, because they have been shown to be associated with good outcomes, and indeed compensation, or at least part of the compensation, is now being tied to meeting those metrics. And then the last big layer is medical student attributes. Every medical student is different. They come to us with a differing level of desire, of interest in primary care, and a different level of readiness for autonomy. And that's something we have to assess student by student before we sort of plan for the interaction with the patient and how that entire encounter is going to be managed. Then there's the lack of continuity. Yes, I know Ms. Smith. I've seen her 8 times in the past year, but the student who's seeing the patient for the first time because he's rotating through family medicine just for a few weeks doesn't. And so they have to get up to speed in a really short time frame on things that we already know. We don't even need to look at the medical chart to remember about our patient. And then of course, want feedback. And this is a great thing. Our students at our institution are curious, and they want to know, and they want to improve. And even if family medicine isn't their specialty of choice, the majority of the ones that I've seen, and I think most of us would agree, they want to learn, they want to do better. They want to know how to interact with their patients and how to interpret and digest that information, and then turn around and deliver plans that work for our patients and that are evidence-based and hopefully lead to better outcomes for our patients. So, how do we teach effectively with all these competing demands and challenges? Is there one style or one method that works perfectly? And when looking at some of the different ways to categorize teaching styles and methods, and there are multiple out there, I pulled up this particular stratification of teaching styles because it's very similar to the RHYME framework when we're talking about learners. Although this one, no one style is necessarily superior to another. It really does depend on the circumstance and the subject. So for the authority style, that's usually a one-way communication. It's the educator to the student, and it's the type of style that would be appropriate. Let's say in the beginning of teaching biochemistry concepts, it makes sense. A lot of that isn't necessarily intuitive and not a very good subject to at least initially start with the kind of dialogue. It really is just giving the information initially. Then there's the demonstrator, and that's completely appropriate when you're teaching something like a procedure or clinical skill, that at least the first time the student sees the demonstration to begin that learning process. Then there's the facilitator, and that's probably the bulk of what we see when we're precepting students in the clerkship rotations, because we are there to guide them and give them instruction and teach and direct and nudge, but they're starting to learn by doing. That's the biggest portion of the learning process is through actually engaging in the skills. And then the delegator is where the educator is treating the student almost as a peer. And this is what we tend to see more between the attendings and the residents towards the end of residency, when they have demonstrated their competency in the main skills. And then when we talk about methods, there are multiple methods, but the two most significant ones and that we see and that you'll see that are tied to the styles we just talked about are expert and Socratic. Expert is the educator has all the knowledge and is sharing that information, and it may be lecture, maybe demonstration, but for the most part it's one way. Socratic is more engaging in an argumentative dialogue, and I don't mean hostile, but in a dialogue filled with questions from the teacher to the student, aimed at encouraging critical thinking and aiding the student to find the answer him or herself by restructuring the information that's already available and using logic and reasoning to get to where they need to be. Now, in the clinical setting, in the clerkship rotation setting where we're teaching, there is no single one of these that is appropriate all the time. And so we really need to consider a better option. And there is one. There's one that Dr. Tysinger taught and I have talked about several times, but we do come back and revisit this on a regular basis as a reminder, and also for our newer faculty and our residents, both the ones who've been teaching students already and those that will be teaching students soon. So for our first year residents, I do want to tell you, you will not be teaching students usually for the first half of the year, but by the second half of the year, you might start to have a student that you will precept, you and your attending will precept, but you will be the initial educator and it will be your patient that they are seeing and working with you on. And so it's very important for you to understand sort of the overview of this structure to help you have a method for interacting with the student that's effective for them and efficient for you. So one way that has been studied quite a bit and has been shown to be effective in terms of providing good outcomes and good information for the students and also efficient from a time perspective is what we refer to as the 1-minute preceptor. And this is the name given to a model called the 5-step microskills that was first really discussed in a paper back from 1992. Originally, and for several years following, it was called just the 5-step microskills model, and it was specifically for clinical teaching in the outpatient setting. The quote from the introduction of that article, which is what led the authors to really try and find a systematic approach for the teaching, that I've included here on the slide is, and I thought it was interesting, untrained clinical teachers tend to give mini lectures rather than conduct discussions, provide inadequate feedback to learners, and allow residents to present haphazardly or bluff their way through presentations. I've got to admit, I probably tried once or twice to bluff my way through presentations, but we have amazing faculty and I never got away with it. So, but the authors looked at that and saw that haphazard approach and then reviewed some of the other teaching models that were in place at the time, but hadn't really caught momentum, and that's because they were either too complicated or weren't effective. And so they came up with this particular model that they employed and then was subsequently employed in various different settings, and there's multiple studies on how this has impacted efficiency and improved feedback in various settings, and we'll discuss at least one of those studies a little bit further in this presentation. So the actual 5 microskills that are employed in the 1-minute preceptor are listed here. Number 1 is get a commitment. We'll go through each of these and what they mean in more detail in just a moment. The second one is probe for supporting evidence. The third is teach general rules. The fourth is reinforce what was done right. And number 5 is correct mistakes. Now it says correct mistakes, that was used in the literature, but you'll see that subsequent studies have changed the language and used softer language, things like opportunity for improvement, which is one of my favorite phrases, or feedback, constructive feedback, or various other terms. So number 1, get a commitment. So a commitment for what? What are we asking the student to do at this point, and how do we know where in the process do we start? The student will usually, a third-year medical student, whether it's at the beginning of the year or the end of the year, usually have no problem presenting the HPI, all the objective information. Usually you'll start to see the hesitation when they get to the assessment and plan or some part of the assessment and plan. And it's at that point when you see the hesitation that we start with the 1-minute preceptor and we jump in as attendings. Now, it's very difficult and very challenging, at least for me, not to jump in. I still sometimes am in resident mode, just want to raise my hand and say the answer, but we're not doing the student a favor by doing that. What we want to do is employ some of these more complex teaching styles and encourage them to do the critical thinking to get them where they need to be. And so instead of jumping in and saying, hey, you should be ordering an A1C, hey, you should be doing this, 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 ask them, what do you think is going on? What tests are indicated? What would you like to accomplish with this visit? And really the cue, although here I put, it often happens in the assessment and plan, really just look for the cue from the student. When they pause and have that look in their face like, I'm not 100% sure I said this the right thing, or they just don't give you the assessment and plan, that's where you go. So what do you think is going on? What do you think the diagnosis is? What's on your differential? Once they give you an answer, then you go to step 2, probe for supporting evidence. And so this is to avoid the bluffing. This is to avoid they happen to guess right, but they don't have a good rationale for it. This is to probe their level of understanding and the information that they have grasped thus far. So the bottom line is why? Why did you reach that conclusion from the questions in number 1? And so some of the supporting type questions that you can ask for this one, for probe for supporting evidence, is what were the findings that led to that diagnosis? Why did you choose that medication instead of another first-line option? And what factors did you consider when prescribing physical therapy or this option instead of that option? The third step in the 5 Microskills is teach general rules. And this is where, after hearing the student speak on both number 1 and number 2, you're going to look at their gaps of information and you're going to help fill those in. And so that's really obvious, I think, for the most part. We should have that information, and it's okay if we don't, but at that point, we also turn around and say, we don't, but this is where I look when I don't have the information. So for example, let's say the issue was about management of hypertension and you wanted to provide a teaching point on that relevant to the issue that came up and where the student had the gap information. First-line therapies for hypertension include ACE inhibitor, ARB, CCB, and thiazides. However, your choice among them might depend on patient characteristics such as ethnicity and comorbidities. Number 4, reinforce what was done right. Good job. Oh, everybody loves to hear a good job. But after the initial, oh, thank you. And you're like, well, now what? I'm not sure exactly what that means. It sounds nice, but it's not helpful without more specific information. Now, I encourage all of you, both for number 4 and number 5, when you get to these portions, and collectively, these are feedback, both positive and negative, I encourage you to focus on behavior, action of the students, not characteristics. For example, here's one example. You consider the patient's lack of transportation and income in selecting a home-based exercise program instead of physical therapy in clinic. This likely will result in better adherence to the therapeutic plan. That was something very specific that the student did and hopefully will lead to a better outcome. And the next one is correct mistakes. Now, I do encourage you that if you are going to describe this particular component because you feel better in introducing each step to the student or in your mind going through that, maybe correct mistakes might not be the best word because it might automatically put the student on the defensive, but I saw this opportunity for improvement as a great way to introduce it. And then be, again, very specific and as objective as possible when defining the deficiency, along with providing a recommendation of what to do the next time. For example, I noticed you did not examine her ear. This is a patient that had a complaint of hearing loss. Although her complaint of chronic hearing loss in that ear may need to be evaluated by an audiologist, a thorough ear exam is essential prior to making a diagnosis and placing the referral as a lodged foreign object or impacted cerumen, or certain abnormalities will call for a different course of action first. Normally, at this stage, I would break everybody up into small groups and we'd run through a couple practice scenarios. But given our current limitations, what we'll do is I will just run through one super simplified interaction, and then kind of give some tips for how to make this better, easier to implement in a way that you get good student engagement, but again, keep your sessions short enough so that you're not impinging too much or disturbing the workflow of the day too much. So I have an example here, and I'll read through the scenario quickly. By the way, the 1-minute preceptor is usually not 1 minute, but if you're pretty comfortable with the way it works and your student is kind of on board with how it works, usually 2 to 3 minutes max. And then we can talk about tips of how to manage additional questions the student may have at the time if your clinical constraints don't allow you to answer them at that particular time. All right, so in our example, we have a student that presents a patient she just saw, 49-year-old female with type 2 diabetes, high blood pressure, hyperlipidemia. Her home fasting blood sugars are usually in the 90s. Last A1C was 1 month ago and is 6.8%. It's on metformin, hydrochlorothiazide, and statin. Last month, her last microalbumin creatinine ratio and BMP were greater than a year ago. Last lipids eye exam were 1 month ago and all normal. Her 10-year ASCVD risk is 4.5%. Vitals and exam were normal except for dry skin and cracking on the foot exam. The student ends the presentation by listing each medical condition, noting that it is controlled and plan to continue current medications. She adds for the diabetes, counseling on daily foot checks, recommendation on moisturizing feet daily, and supportive shoes. The student then looks at you with a question on her face as if to say, was that right? So you can start that interaction by noting that she did not mention the need for screening for nephropathy at this point. Are there any routine screenings or testing indicated for this patient based on her chronic conditions? So don't jump automatically to, we got to order the microalbumin and the BMP. Instead, give the student an opportunity to get there on his or her own. And so with a little bit of prompting. By the way, I apologize for putting that paper up in front of the camera. I didn't even realize it. Thank you for the notice. So then we start with that question. Give the student a chance to tell you what's missing. And she takes a second to think about it and then says, yes, I think we should check her BMP as well. Then you're going to probe for supporting evidence. Why do you think that? She answers, because we check kidney function once a year for diabetic patients, and this patient is overdue. At this point, you're going to do the teaching pearl because there was a gap of information. She said BMP, but not the microalbumin creatinine ratio. And so you're going to tell her that is correct, but we also check for proteinuria. We reference the ADA guidelines. We explain to her we do that at least once a year. And then we tell her that we're going to order not only the BMP, but also the microalbumin creatinine ratio. At this point, we're going to start the number 4, which is letting her know what she did right. And we can start that with let's turn to feedback. And I'll come back to why we should put that phrase in the beginning. We explained to her that her physical exam was very good and very thorough, and that she caught the foot cracking, and that was very important in this situation, and especially with the diabetic, given that foot cracking can lead to increased risk of infections and the importance of managing that. And then now we get to the area where we have an opportunity, room for improvement. And you mentioned that you had noticed that when you went back in and just touched base with the patient, that she actually hadn't been compliant with one of the medications. So you can bring that up and saying at the end of the visit, the patient admitted to not taking her hydrochlorothiazide regularly because she had been feeling really good. Now, the room for improvement for the student is including compliance in your obtaining an HPI is very important, as non-compliance, as being aware of non-compliance can definitely affect your plan. All right, so the 1-minute preceptor works best when you lay the groundwork for it. Students always perform better when they know what's to come. What is the plan? How does it all work? And what are the expectations? So number 1, this is on the front end when either you first meet the student or at the beginning of the day before the rush of the clinic day starts. You're going to want to make sure that that student is properly oriented oriented to the site. And so you're going to want to make sure they understand the site. You know, where do patients get triaged? Where are the rooms? How do they find the things they need to get through a typical patient visit? You're also going to want to make sure they understand the workflow. And they also should know who's your patient panel. What types of patients do you see generally? What kind of issues? It might be completely varied. Some of us do take care of people from, from birth to death, but there are others that have more specialized populations. And so you might want to share that information with the students so they have an idea what to expect during their time with you. The next part is specific expectations. So we recommend for students that you assign to them 2 to 3 patients in a half day. And in some cases, 2 might be perfectly appropriate. And in their very first session with you, you might want to do either none or 1 if you prefer them to shadow and understand the workflow of your clinic. But that'll help the student from getting overburdened and also help make sure that the time you spend with them is quality time instead of just trying to catch up on every single patient if they're trying to see every single patient. If they do want to see more patients, one thing that I do, and I know various other faculty members do, is to have them shadow you for several other patients that you think might be interesting or have some learning points for the student. And then the expectation is also 1 to 2 notes per half day. And then explain how you want the notes. In EPIC and certainly on the UT Health side, we can actually use the student notes. So to the extent you spend a little time on the front end making clear your expectations for the notes, that helps on the back end. The students provide a note that is most helpful to you. And I promise they all love knowing that what they're doing is having some impact in helping you in patient care. It also makes them feel that much closer to being ready for patient care. And then another thing to cover with them when you're doing these preliminary expectations is let them know where they will present, how the teaching and the feedback is provided. Some providers prefer to do it in the actual exam room, do everything in the exam room in front of the patient. And that's fine. I just strongly recommend you discuss it with the student ahead of time so that they're not caught off guard and it's not potentially embarrassing in front of the patient. Others will say, we'll wait till we're completely done, then we'll come back to the desk, have a few moments to ourselves. You can present, we can discuss, and then we'll go back and wrap up with the patient if appropriate. And then explain to them how you will teach and provide the feedback. And in most cases, we strongly encourage that all the components of the 1 minute preceptor be done during the presentation, during that portion where after they've presented the patient and you're getting to the point where you're trying to get out that extra thinking, critical thinking and reasoning and plan from the student, that's where that precepting should occur. And then if you want to do an additional wrap up at the end of the half day with the student, you can also let them know, by the way, we'll also cover any additional questions you have at the end of the day. That'll help you with time management as well. Then the other specific component that I encourage everyone to do is huddle with the student at the beginning of the half day, or if you have them for the whole day, And at that point, you can assign the student the patient so they have a chance to chart check. And so because they lack the continuity, they'll at least be able to research the patient enough to not feel like they're scrambling at the last minute trying to understand what's going on with the patient. And you can also prep students if there's specific things you want to focus on or you don't want to address in the visit because you've recently addressed them or you plan to in a following visit, then you can do all of those things so that the student is not guessing and potentially spending time on things that you don't have planned for that patient. And then also give the students some time expectations. Tell them, I would like for you to spend approximately 10 to 15 minutes, come back, present, then we'll go together, spend a few more minutes and wrap up. I think that's perfectly reasonable. Or let them know, if you haven't come out in about 15 minutes, I'll usually peek in just to make sure there's no problem. We'll wrap up and then we'll come back and talk about the patient. All of that helps to not catch a student off guard in front of the patient, which can oftentimes be a little bit embarrassing or off-putting. All right, so tips for using the specific microskills. Now, this is when you're actually in the moment and they've presented the patient and you're now talking about getting the commitment. One really important thing is because all of the patients at RBG and the MARC and pretty much every single location have 3, 4, 5, 6, 7, 8, 9, 10 chronic conditions, and their presentation might get long. When you're talking about the precepting portion, you don't need to teach everything on every issue. We encourage you to focus on one area, both in terms of getting the commitment, pulling some additional conclusions and information from the student. Just pick one issue, one area per encounter. And the same thing for the general rules. Per each patient encounter, just focus on one teaching item in that moment. And if you've had that student for a long time and they've shown competency and they're doing great, and there was nothing in either the presentation or in steps 1 and 2 that indicated a gap of knowledge, then potentially you can skip number 3. But I do encourage you to try and find at least one teaching point with every encounter. And then for feedback, so there was a study that showed in a clinic in the practice where this was implemented, where the microskills were taught to teachers, and then the interactions between teachers and students were observed, there was an improvement both in the amount and the specificity of feedback. However, the student perception of that did not change. And Dr. Tysinger and I had talked about the study on a couple of occasions, and I keep mentioning him because he's my mentor in this subject, and he knows much more than I probably ever will in this area. But one of the things that he had observed, and I'm now observing in my role, is that even though we're providing feedback, the student might not actually perceive it as feedback. And so introducing that segment of the interaction with the label of feedback can be helpful so that the student understands, wow, yes, this is feedback. This is what I should be looking for. I should be looking for the pearls I can grasp and then change my behavior so that the next time I do better in this particular skill set. I do encourage you to do 4 and 5 in the order they're presented. In other words, start with the positive portion. Try to identify something they did really well. Part of that is to help establish trust, to convey to them that you are interested in everything they do, whether it's good or bad, in a way that lets them know what they're doing well and how they can improve. And I think that helps establish rapport so that when you get to number 5, which is the more constructive feedback, they are more receptive to hear it. And again, strongly encourage you, always focus on behaviors and specific acts or omissions and never student characteristics. So those are all the pearls I have on the 5 microskills, the 1-minute preceptor. Now I do share this really important caveat. There are more seasoned faculty in our audience today who have their own methods and they work extremely well and they teach effectively and efficiently, and for whom, even though they don't employ the 1-minute preceptor, do have a system and it works well. I can almost guarantee you every single one of those faculties employs in one way or another each of these components, but it may not be that style, and that's fine. But I want to make sure that everyone is aware of this, especially our residents who are starting to teach or have very little experience, or for our newer faculty. This is a nice go-to framework when you're not sure how else to manage that student interaction and you're trying to get it all done in a very short time frame. All right, so in sum, competing demands, changing environments, evolving medicine, and varying student attributes make teaching in the clinic setting very challenging. The 1-minute preceptor model creates a systematic framework for teaching and providing feedback to students in the outpatient setting. Employing basic strategies to advise students of expectations and create a positive learning environment can make implementing the model more effective and efficient. So I thank everyone for their time today. I really appreciate it and enjoy being with this group always. And I'm going to open up the floor to any questions. All right, let me just check the chat. So let's see. Do you have any advice on supporting students, residents who have difficulty with efficiency in the clinic? And this is from Abigail Myers. So yes, and part of it is going to be an individualized assessment. Where is the inefficiency? And it might require sitting down and having either following that student or resident for 1 or 2 encounters to understand where the inefficiency is. Is it a failure to focus during the patient interaction? Is it trying to manage workflow? Is it taking too much time and trying to reach the assessment and plan. So you need to understand the needs of that particular resident or student before you can really address it. But that's really important, because if you have a resident or student that's very inefficient, obviously that creates a lot of different challenges and you need to address it. I don't know if you want to share like a particular circumstance and maybe some recommendations on how it can be addressed. Feel free to do so. Or the other thing is, if you do have an issue with a specific resident, obviously speaking to Dr. Nato or Dr. Weimers or Dr. Falcone is very important. Also, if you have a concern about a specific student, reaching out to myself or Dr. Andrew is also very important. But initially, at least doing some kind of evaluation to understand where the inefficiency is occurring is going to help you find the right solution for that resident or student. Any other questions?
Is it okay if I just share a comment about?
Yeah, please.
So in a lot of ways, I think teaching outpatient is harder than teaching inpatient, because if the resident or the student disappears for an hour to go talk to a patient, well, you've got other work you can do. Whereas in the clinic, you need to control the time hack a little more. So I think you do need to manage that a little bit. I think one of the strategies, if you got a particularly inefficient, or actually most of us were inefficient when we first started this person, and you can do what Michelle suggested, is give them just tell them I'm coming in 20 minutes or 15 minutes or at some point, and so then you just jump in where they are and they expect it, and they might even have told the patient, the physician I'm working with is probably going to come in about 15, 20 minutes and we'll get started. So I think that helps them control their interaction with the patient. So I think that's a great strategy, but you don't need to be controlled by, gee, the student hasn't come out of the room yet, or you need to drive that a little bit and control that. Just one comment that the sixth micro skill, I guess. One thing that I've had to work on is sometimes if you're trying to explain something in front of a patient, that could be a little bit challenging. So I think you really need to, choose your words so that doesn't make it the sense that the student doesn't know stuff. And so sometimes if you have specific teaching points, you can wait till you're out of the room to discuss it, or if you want to explain it right then, I usually I'm going to start with some of the basics, and I know you know a lot of the basics, but just so that the patient will understand some of the discussion, or some such phrase as that, just to give them a sense they know something. You're not trying to show them up like they don't know anything.
Agreed. I think those are all great points. And that's always very delicate, is when you're asking the student to present in front of the patient. So I do encourage you to think about it, and maybe always save step 5 for a separate discussion outside the patient room, or try to, maybe that might be better. And more than anything, I'll always want to avoid the student feeling embarrassed in front of the patient. But I think most of us do that normally, routinely.
I think that's a great point. I think one thing where you have to do it in the room would be, for instance, if you're demonstrating a physical exam. Mm-hmm. So that might be an example where you have to do some explanation for the patient. Some things are best done as an example. Mm-hmm. Mostly, you're right. Outside the room is usually better.
Agreed. Any other questions? All right, well, everyone is free to reach out to me either at my phone here in the med school or email. And again, it was my pleasure to present to you today, and I look forward to seeing you all someday soon.
Awesome. Everyone, I want to just remind you, quick reminder, we have the evaluation for Dr. Rodriguez's presentation today in the chat. Please evaluate her. It's important for the program as well as for Dr. Rodriguez. Thank you, everyone. Have a good day. Thank you.
Thanks, Michelle.
Bye-bye. Thank you.
Rodriguez.
Bye-bye.